Coming up, hips, knees, and bones. What you can do to keep them healthy.
Going online to help keep the doctor away.
And a different way to travel that isn't for everyone.
All this and more is next on Time for Living. Hello and welcome to Time for Living. I'm Howard Nielsen.
And I'm Janet Jagalian.
Today we're taking a look at hips and bones and how we can ensure that we're doing the most to prevent fractures and breaks.
We'll also show you a program that helps make use of the internet to help us lead healthier lives.
And we'll see how some people travel on vacation without leaving the comforts of home. We begin with a look at how osteoporosis affects our attempts at staying healthy. As many as 25 million American women and men have osteoporosis, and another 25 million are at high risk of developing it.
While it's best to increase your calcium intake from foods, many people are relying on supplements to build stronger bones. But as medical reporter Kathleen Quinn explains, if you're not careful, you could be wiping out the pill's effectiveness.
Osteoporosis, or the weakening of bones, is a silent condition because it progresses for years without any signs or symptoms. By age 65, 3/4 of women are affected, and half of all women over 50 will suffer an osteoporosis-related fracture. Despite good intentions, women who worry about it feel it's hard to keep up the fight.
You try to keep up, but there's just too many things to keep up on at one time.
I probably do not get as much calcium as I should.
Those who don't get enough calcium in their diet often turn to calcium supplements. But health experts say if you're taking them with a cola or soda pop, you may as well not take them at all.
Soda pop, cola, has phosphates in it. And if you take your calcium pill with a soda pop, the phosphate will bind with the calcium and you won't absorb it.
Dr. Becker is a pathologist, a doctor who treats patients through laboratory medicine. He recommends taking supplements with water or juice so the calcium is easily absorbed. Calcium is the most important mineral in bone, so the more you take in, the stronger bones will be and the lower your risk of osteoporosis. The best sources are dairy products and vegetables. And to keep your bones strong, do regular weight-bearing exercise, limit alcohol intake, and don't smoke. Also, talk with your doctor about hormone replacement therapy if you've had early or surgically induced menopause. Osteoporosis is preventable, and pathologists have new tests which may be useful in early diagnosis.
We have blood tests that can detect enzymes that show that bone is forming. We also have some urine tests that show us the products of bone breakdown.
Put frequent deposits of calcium into your bone bank, and regular exercise can help your bones last a lifetime. It's never too early to make the investment, and never too late to have an impact. For more information about osteoporosis, call the College of American Pathologists at 1-800-LAB-5678. This is Kathleen Quinn reporting.
Again, that number to call for the College of American Pathologists is 1-800-LAB-5678. When we come back, we'll focus on healing of hips and knees with an expert on bone medicine, so stay with us.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Welcome back to Time for Living. Joining me now is a national expert in the study of bone medicine, Dr. Samuel Doppelt. Dr. Doppelt is on the clinical staff of Massachusetts General Hospital and the chief of orthopedic surgery at Cambridge Hospital. He's also an assistant professor of medicine at Harvard Medical School and a consultant to the clinical center at the National Institute of Health in Bethesda, Maryland. He has lectured on the field of orthopedics in Singapore, Bangkok, and all across the United States. Welcome to Time for Living, Dr. Doppelt.
Thank you. Nice to be here.
We've got all kinds of things before us to look at and to learn from. And I guess it's important to say that knee surgery, hip replacement surgery is not as unusual now as it was many years ago.
That's correct. There are, because of the changes in advances in design of the prostheses and a better understanding of rehabilitation of patients, the number of patients that are candidates for joint replacements is increasing. Some statistics from a few years ago, there were about a little over 200,000 total knee replacements done per year in the United States and about 250,000 total hips done.
Are most of those because of arthritic conditions or osteoporosis?
Well, actually both. The majority are due to arthritis, degenerative arthritis, rheumatoid arthritis. Some of the hips, of the 250,000 hips, about 100,000 were hemiarthroplasties for femoral neck fractures, which are fractures which are common in the osteoporotic population.
But explain what a hemiarthroplasty is.
Okay, well, if I have a model here,
Okay.
if I could go to our model. This is a model of a hip. This is the pelvis, and this is the upper end of the femur. And the femur has a head and a neck, and it fits into a socket in the acetabulum. And when you sustain a fracture of the neck and it is displaced, you can lose blood supply to the head, and we replace that then with a prosthesis in which you replace only half the joint. This is a type of hemiarthroplasty in which you would insert the stem down the canal of the femur, and you would choose a size of a femoral head which matches the patient's femoral head, and then that would fit inside the socket. Right, and so you've only replaced half the joint.
Now, I think I read somewhere where they now have such precision ability to get the shaft directly where it should go. But there's no making mistakes anymore. Is it driven by computer type of studies or models?
There are some places where, some institutions where they are using computer-driven equipment.
Yeah. Is it like a roto-rooter type of thing? Is that what I read?
It's not quite like that, but a little bit like a roto-rooter. However, the majority are still done with handheld instruments in which the surgeon has to put down a drill or a rasp, which is like a file, and contour the inside of the bone to fit the stem. And the stems come in different sizes, and the object is to get one that fits perfectly.
Now, when you no longer have any blood supply going to the head of the femur, and you put this metal unit down into the prosthesis into the shaft, is there any danger that you're not going to get blood supply to that bone so that that will stay healthy?
No, that isn't That is, well, there are some problems. The blood supply to the rest of the femur isn't a problem, but when you put a metal stem inside of a bone, there are some problems that occur both on this side as well as the socket side. On the femoral side, you can eventually get loosening, where the bone around the stem disappears, and so the stem will get loose, and then that can cause pain. In addition, when you have a metal ball rubbing or articulating with this bone and cartilage socket, that is not exactly normal, and you can get increased wear of the socket, and so you can get some migration of this ball into the socket.
Is there ever a likelihood that the metal piece can protrude again through the hip?
It can.
Or through the pelvis?
It can. The hemiarthroplasties work very well, but eventually, over time, this can start to migrate through the pelvis.
So does that depend on the condition of the pelvis? I mean, if the arthritis is very advanced, does it have an impact on that part of the bone as well?
It does. If there is, for example, if someone has severe osteoporosis, the bone is softer and will yield to the forces of this metal ball pressing on the socket. If they have arthritis of the socket, then you would do a total hip rather than a hemiarthroplasty. You'd have to replace the socket side.
Do you have to worry at all about the age of the person? At one time they said you have to wait till you have to be a certain age to make sure that it takes well, that it's going to last you the rest of your life and not have to be redone again. Is that still a concern with surgery?
It is a concern, but less so. I mean, first of all, I don't think age should be a deterrent. The most important thing is not the patient's chronologic age, but rather their physiologic age. What we're trying to do is restore patients to a more normal lifestyle, maintain their vitality, their activity, and restore function. So if somebody is, let's say, 80 years old, but that's their chronologic age, but physiologically they're active and doing a lot of things, that should not be a deterrent to having some procedure done.
They shouldn't feel as though, oh, I'm going to be laid up even longer because of my age. It's going to, the rehabilitation period or process is going to be lengthened because of my chronological age?
Not really. The rehabilitation we have developed, it started in California and has gone from west to east, the development of critical pathways to speed the recovery of patients after joint replacements. In those types of, under those circumstances, we teach the patients some of the physical therapy activities actually before they get into the hospital. And so, let's say 10 years ago, patients were staying in the hospital for 10 days, 2 weeks. Now they're being discharged in 3 or 4 days.
Yeah, and they're bearing weight on that leg and a partial weight.
Most of these patients that have hip and knee replacements will be out of bed the day after surgery and start walking the day after surgery.
Amazing. Now, is there ever a time when an insurance company will not pay for this kind of procedure?
In general, that has not been a problem.
Regardless of age?
Regardless of age, that's right. I have not had any problems
because
with that.
there are often, women suffer from osteoporosis in large numbers, obviously, and they will break hips, and that's the question I want to find out. Do they fall and break their hip, or does the hip break and then they fall? Actually,
it happens both ways. Most people think that the only way you can break a hip is to fall on it first. But if, it's hard to prove, but if you talk to patients over and over again in the emergency room, it is clear that some patients will actually break their hip just walking across the floor and turning. They will feel something pop, they'll have pain, and then they fall. So it can happen that way.
Now, when is it a replacement that is done, and when is it just some other kind of pins and screws and other kinds of surgery that is performed?
Right. If there are two common types of hip fractures. One is what's called an intertrochanteric hip fracture. This is the head, neck, the greater trochanter, and the lesser trochanter, and the proximal femur. And if you have a fracture that runs along in this direction, that's an intertrochanteric hip fracture, and that is usually fixed with a plate and screws, and they usually heal.
And how would they go? Where would the plate and screws go?
Well, there would be a plate on the side, a long plate on the side with about 3 to 6 screws on the side, and a very large screw that goes this way up into the head and neck, and that holds the whole thing together until this fracture heals.
And there's no problem with blood supply to keep that bone healthy?
No, very rare, very
Okay.
rare. This type of fracture almost always heals.
Is that a common fracture?
That is the most common fracture around the hip. Is the
And how long is a
intertrochanteric
person on
fracture.
the operating table having this done?
Oh, well, depending upon what we call common, how many fracture pieces there are, it may be an hour and 20 minutes to maybe 2 hours.
And on average, what would the recovery rate be for this particular surgery, this common hip fracture?
These patients would be partial weight bearing or either non-weight bearing if it's very osteoporotic bone. If it is better bone, they may be partial weight bearing, and the fractures are usually healed by about 3 months.
And how soon do they really begin active physical therapy?
Again, the day after surgery, they're out of bed, and we try to get them out of bed and walking the day after surgery.
And when they likely, I know some of these answers because I'm a physical therapist, but that's okay. How long does it, on average, take a person to go through rehabilitation and go home and begin to resume a fairly normal life?
Well, if they can be partial weight bearing and there aren't other problems with stairs and so forth at home, these patients will be home in 2 weeks.
And what about the rate at which they can begin to resume, like playing golf, playing tennis? Are they ever able to really get back to some of the real active?
Well, if we're talking about the intertrochanteric, that type of fracture, yes. Those fractures are healed. When they are completely healed, those patients, there may be a little bit of shortening of the leg, but other than that, which can be accommodated by a shoe lift, they can go back to normal activities.
Okay, now just quickly tell me about the other kinds of fractures.
Well, the other kind of fracture that we were talking about is the femoral neck fracture, which requires the hemiarthroplasty. If it is the problem with the femoral head is that it has a very tenuous blood supply. And so if the fracture is non-displaced or minimally displaced, we may choose to just put a pin in it. But frequently the head has fallen down and it has ripped the blood vessels that go to the head. And under those circumstances, what you do is you remove the head and do a hemiarthroplasty. This happens to be an older style Austin Moore, but there are others that are more modern in design that are what we call bipolars.
Are there any plastic prostheses that you use, or is it just metal?
There is plastic. In the bipolar, which I don't have a sample of, it has a small head and then a outer shell with polyethylene around it, and that's supposed to help reduce friction in the acetabulum.
No, nothing ever breaks down with plastic, but what about the metal? Does that usually stand up pretty well too?
The metal stands up well. The problem actually is the polyethylene. There is polyethylene wear, and that's true for the total hips and the total knees, that the sort of the weak link is the polyethylene.
Let's move on to the knee, because more and more people are having total knees done, and at one time, I mean, that was sort of unheard of. I mean, you used to go in for arthroscopic surgery and have a little ligament fixed here and a little ligament fixed there, or cartilage damage that will be taken care of. But now you reach a point where you really have got to change that whole knee. And what determines when you reach that point?
Well, I think the point is reached when the patient is no longer able to carry on the usual types of activities that they consider important in their lifestyle.
I mean, like pain will be limiting them?
They will have pain, loss of motion, difficulty walking, difficulty climbing stairs. A person who, let's say, a year ago was able to walk a half a mile now can barely walk a block or two and needs to use a cane or a walker. And they're mentally young and vital, and they want to stay active.
20 years ago, though, the orthopedist would give them some aspirin and a cane and say, maybe you need a brace or something to help you, and
that's true.
Let you go with that.
That's true, but the results of joint replacements are so much better now than they were then.
They are.
That you can do these replacements and have somebody up and walking the next day and out of the hospital in less than a week.
Doctor, is it sort of a last resort surgery for the knee, or do you try doing other kinds of arthroscopic surgery first?
Well, that's a good point. It depends on what the pathology is. For many patients who have mild or moderate arthritis, they may benefit by having an arthroscopic debridement, where you wash it out, sort of like changing the oil in your car, get rid of the debris, and that will give them some relief. Other things that can be done are use of anti-inflammatory medications, which are very popular, and simple things such as individuals who are overweight if they will lose a little bit of weight, that will go a long way to reduce their symptoms. So first you want to do the easy things and the non-invasive things, and then later on, if those aren't enough and the patient's lifestyle is still significantly limited, then a joint replacement is a reasonable thing to do.
If they have osteoarthritis, is that what they would be more likely to have as a reason for replacing the knee?
Yes.
Or would rheumatoid arthritis be a situation as well, or is that not as likely?
No, both. Both can both are causes of deterioration of the joint. The arthritis is the inflammation of the joint and the loss of the normal smooth surface of the joint. When that happens, either from osteoarthritis or rheumatoid arthritis.
Now tell me just what you replace.
Okay.
What is the procedure all about?
Okay, this is a model of a knee, and this is your kneecap, your patella. And if you look inside the knee, this is the femur, the thigh bone, and this is the tibia. And if you look at this gray area, these are the femoral condyles, the articular surface of the femur. And this surface and the blue surface on the tibia, the upper surface of the tibia, is normally covered with very smooth material called hyaline cartilage, and it has a very low coefficient of friction. And when, however, you have damage to that cartilage, then you start developing, you have wear, and you're rubbing bone on bone rather than smooth cartilage on cartilage.
And does some of that cartilage then loosen up and start floating in the knee?
Right. You get little particles that are free floating around. That causes inflammation of the joint and causes further wear.
Does it also cause the knee to lock in positions when you're walking?
Well, the problems you have, yes, you have pain, swelling. You may have a locking of the knee or giving way of the knee, and many older individuals too may get torn menisci, the cartilages, the little rubber bumpers that are present inside the knee, just like a younger individual, and that can cause problems, and it's easy to fix that.
Before we go on to the actual surgery itself, there was an article in the Globe this past week about some harvesting of your own cartilage that can be in the laboratory grown to help replace the defective cartilage that you have in your body. Is that the procedure that is currently in mode right now?
Well, one of the problems is that if you know somebody has a damage to the cartilage surface, the natural history is that eventually they will get arthritis. So everybody is seeking some solution to prevent that problem from producing further arthritis. This auto-transplantation of your own cartilage is one method in which arthroscopically you remove some cartilage from a not particularly important area, such as the edge. It goes back to the laboratory, to the company. They grow the cartilage cells, give it back to you, and then through an open procedure, you replace the cartilage in the defect.
Do you like that concept, or would you prefer to do a total knee?
Oh, I would prefer not to do a total knee, I think.
Because it is radical.
It is radical, yes. Right, exactly. It's much better to do a smaller procedure. You can also take plugs of bone from the edge of the femur and remove a core of bone and place it where there is another known defect. Take it from a less important area and put it in a more important area. In this area, which would be a weight-bearing area, which is where you're putting your forces when you're standing.
Is the United States in the forefront of research in this whole area of orthopedic surgery for hips and knees, or is this being done elsewhere?
It is being done elsewhere, but I think most of the advances are coming from the United States. The United States is clearly a leader in the area.
How about, is there any special part of the country where a lot of this is being done? I mean, on the east and west coasts, or is it hard to sort of pinpoint?
It's a little bit hard to pinpoint. There are many good institutions throughout the country that are doing research in, for example, cartilage transplantation and so forth. I know in Finland they were doing some work with the auto cartilage transplantation.
Okay.
Right.
Now tell me about the total knee. What is done?
Well, if the problem, again, is that this surface and the upper surface of the tibia is worn away. And so you replace the surface, the articular surface of the femur with a metal surface.
That looks mighty impressive.
And this is made out of highly polished stainless steel.
Yeah.
And you can see on another model here, this would basically, you pick a size that fits
the bone.
Yeah. Okay, and you have to, the surgeon has to make a series of cuts to make the bone fit that surface.
So what you're
Okay.
doing is really making new articulating surfaces of the femur and the tibia.
Exactly. And so the femur now has this stainless steel end, which is the new surface. And then on the tibia, you would make a cut across the top of the tibia and remove that upper surface, which has the damaged cartilage, and that is replaced with a metal tray,
Yeah.
usually with some sort of a keel. And then on top of that tray goes a polyethylene tray.
Yeah. And that
And-
moves very smoothly with,
Right, and
with
then
the stainless steel.
Right, and then you have the stainless steel rubbing against the polyethylene.
Now, what do you do about all the ligaments that hold the bones together?
Well, the ligaments are the inner and outer ligaments, medial and lateral collateral ligaments stay.
Oh, so if you don't, those aren't damaged to begin with.
It helps not to have them damaged, but if they are damaged, you
Yes.
can do surgically ligament balancing and replace some of the function of those. There are two ligaments inside the knee, which people have probably heard, the anterior cruciate ligament and the posterior cruciate ligament. In that
Our
instance,
weekend warriors probably have heard of
right,
that.
the anterior cruciate is a commonly injured ligament. The anterior cruciate in the total knee replacement is always sacrificed. It goes.
I see.
The posterior cruciate is sometimes sacrificed and sometimes not, depending upon the style of the prosthesis that you use. And you can have a prosthesis, for example, this type of a tray, which will lock onto a little hook on the femur, and that can replace the
Recovery
posterior
time
cruciate.
for this kind of surgery?
Again, patients will be up and walking usually the day after surgery, usually out of the acute care hospital within 3 or 4 days.
And able to return to normal activity?
Able to return to normal activity probably within a couple of weeks.
Incredible.
It is.
Absolutely incredible. And you think that it's not uncommon to have both knees done at the same time?
That is not uncommon. I mean, patients can choose how, if they have severe disease in both knees, if you don't have sort of a good leg to stand on, as they say, you can do both at the same time.
Dr. Doppel, thank you so much. This has been fascinating, and I'm sure people feel as though there's reason to hope that if they have advancing arthritis and they can't move their hips and knees, they can always get a new one.
Sure.
Thank you very
good.
much. When Time for Living returns, going online to help keep the doctor away and gain some peace of mind, so stay with us. Accessing the internet for information is becoming second nature for more and more people, but for one segment of the population, just turning on a computer can be intimidating and complicated.
As Jim Harriet reports, a new pilot project is teaching older Americans how to get online.
There you go, you've got it. Now hit enter. You see the hourglass? So you're in
a way, these older Americans are pioneers.
It's completely new. I had never worked on a computer before.
They're participating in a pilot project funded by the National Institutes of Health. The idea is to help older people tap into the wealth of health information on the internet.
So if they have, say, a prostate problem or a cancer problem or a macular degeneration problem, whatever the case may be, to be able to go and get the information at their fingertips and to walk into a doctor's office with that information.
And be better, smarter healthcare consumers. The project generated an enthusiastic response at this senior center in Wheaton, Maryland.
The doctors don't have time to educate you on everything, and I feel that I'm a diabetic and my husband has a heart condition, so I felt that I had the responsibility to find out as much as I could.
Now, here you have to decide what you're going to search for.
It's been very helpful, certainly, and they've been taking us through the steps one by one.
And while this class is focusing on accessing health information, of course, when you're browsing the web, you could end up anywhere. I'm Jim Harriet reporting.
Well, that's certainly making good use of the internet.
Absolutely. Now, if you want to suggest a person or program deserving a Second Effort Salute, then write to us at Time for Living, care of Second Effort Salute, Post Office Box 8452, Boston, Massachusetts, 02114.
Or you can leave your suggestion on our voicemail by calling 800-232-7213 or fax us at 617-329-1774. We'd love to hear from you. When Time for Living continues, how to take a vacation and never leave home, sort of. Traveling Around is coming up next. Over the past year on our Traveling Around segment, we've taken you to the German countryside, the deserts of Mexico, and even the tropical island of Singapore. But today, we're changing our course a little.
If you're the outdoors type that enjoys traveling to new places and you don't mind roughing it, then you might want to go RVing. Some say it's an economical way to see the country and meet interesting people along the way. You know, over half of the RV owners in the United States are over 55, and for many of them, home is where the RV goes. Jim Harriet has more.
If you're traveling down here, you can see a lot more. Up in airplanes, you're flying over it, you're not seeing anything.
We're just freer now, and we enjoy moving around the country.
It's a great, big, beautiful country out there. You just got to take your time and see it.
The Kays from Jacksonville, Florida, have been taking their sweet time. They've been vacationing like this for over 40 years.
We like camping because the people are nice, and it's more friendlier than a motel.
Normal rate of camping is between $12, $30. And when you go to motels, what's it cost you? And then you get a dumpy room, then you get people with dogs, and you catch the fleas.
Dogs are welcome at Cherry Hill Park in Silver Spring, Maryland, where you'll often find resident Mary Stephen with her dogs, Peanut and Charlie.
We just decided to unload it and simplify our life.
The Stevens sold their house in Virginia and bought this $67,000 motorhome, fully equipped with all the modern conveniences of a traditional home.
And of course, this is the usual position for working at the computer. The small amount of energy, electricity, propane, gasoline that we use, if you add that all together, I would say it's probably only maybe 25% of what it would be living in a regular house.
Home is where the RV goes for many folks, but they are the first to admit it's not for everyone.
You don't run the coffee pot and the hairdryer at the same time, you know?
Don't buy right away. Try it yourself first and see if it's for you.
The benefits for an RV lifestyle really depend on the individual, but for the most part, it's the opportunity to meet new people and see new places, to have experiences that you really couldn't have on your own block or on your own main street.
I'm Jim Harriet, reporting.
If you think you might be interested in the RV lifestyle, call 1-888-GO-RVing. You can get information on rental sources, a list of campgrounds, publications, and clubs.
Coming up next, Time for Living's financial expert Steve Burke answers a viewer's question that we can all learn from, so stay with us.
Welcome back to Time for Living. I'm Howard Nielsen.
And I'm Janet Jagalian. Oftentimes when we try to plan or sort out our financial situation, we don't know what questions to ask.
Well, one viewer took action and decided to ask Time for Living's financial expert Steve Burke what questions to ask. In today's Health, Finance, and More, Steve Burke has the answer.
In recent programs, I've been suggesting that you ask lots of questions relative to the product or strategy being presented to you. One of our viewers said, That's a good idea, but what are the questions I'm supposed to ask? With that in mind, I thought it would help if we talk about mutual funds by asking lots of questions about them, things you should know. One of the first questions you should ask is, when I retire, can I receive a certain amount of money every month from the fund or funds? The answer is generally yes. It is possible to receive a specific amount on a periodic basis or a percentage of the value of your fund or funds. This allows you to anticipate an amount of money each month, quarter, or year for budgeting purposes. It's important that you are constantly aware of the value of your fund so that you don't accidentally decimate your asset. A practical approach is to determine what the 10-year history of the fund or funds has been. That done, plan to take less income than your fund should generate. Example, if your fund has been realizing a 10 to 12% average return, consider drawing down 8% annually. This gives you some protection from overdrawing the account. However, always keep an eye on the balance. Remember, fund values go down and up. You might want to stop or change the income stream you are receiving to avoid a zero balance. What kind of fund should I buy or have in retirement years? Some simple approaches. Funds with a 10-year performance record which impresses you rather than a hotshot new fund which hasn't been around for the downs, but only the ups. A fund with an investment philosophy which is in tune with your thinking, conservative, aggressive, or moderate. Diversify your funds. The old not all the eggs in this basket approach, since there are over 7,000 mutual funds out there, you have a lot of choices. Also, by investing in different funds, you can adjust your risk. Remember, the stock market mutual funds arena is risky by putting monies in those funds whose objectives seem in line with yours. And do some research, if only to ask lots of questions. Where can I get objective information? There are a number of sources, Wall Street Journal and Morningstar Incorporated being two of the better-known places for information. Once I've invested my money, can I change to other funds or other products? Certainly. But again, make haste slowly because funds go up and down. You don't want to spend your time guessing about timing. Better to stay with a good solid family of funds which allows you to move around in the family and thus minimize fees if you choose to make any moves at all. Generally, it's good sense to ride with the fund or funds you originally picked unless very obviously you have made a mistake. The good funds have a tendency to increase in value, albeit there may be some down times. Can I avoid taxes by reinvesting my dividends, interest and capital gains with my fund? No. Except in those cases where you have a mutual fund or funds in your 401k, IRA, some other form of pension plan, or possibly in a variable annuity or variable life plan, which have some of the characteristics of a mutual fund and whose returns are tax deferred. If your money is not protected by some of the aforementioned products, you must pay taxes even if you have reinvested the returns from your fund and never cashed a check. What sort of fees or commissions can I expect to pay? There are fees, if only the type called 12B1, which are very hard to define in dollars, but they are there nevertheless. After all, like any business, mutual funds need to be paid for providing their services. In many cases, you have a choice of how to pay these charges. Some of you have heard of no-load funds. The fact to keep in mind is that there are fees and or commissions up front, in the middle, or at the end of your relationship with any fund. No-load simply means they have a way to be paid which is more palatable to some people than load funds, which also have different ways of being compensated. It's my suggestion that you use one of the many honest, able representatives available, unless you want to do all the necessary homework yourself. Ask them how they get paid and what their commissions and fees are. And don't do business with someone unless the chemistry is good. Your common sense has gotten you this far. Keep on believing in your judgment about people and things. This is Steve Burke, Time for Living.
If you have any additional questions regarding mutual funds or other financial topics, you can write to Steve at On Time for Living, care of Health Finance and More, P.O. Box 8452, Boston, Massachusetts, 02114.
Or you can leave your comments or questions on our voicemail by calling 800-232-7213 or fax us at 617-329-1774. We'd love to hear from you.
When we come back, discoveries of Alzheimer's that may affect you. Find out if your genetic makeup is fighting back.
Welcome back to Time for Living. Alzheimer's is a crippling disease affecting thousands of families each year. Every day, the medical community seeks ways to solve the mystery or at least slow the effects of this dreaded disease.
The latest question being asked is, are some groups of people genetically immune from Alzheimer's disease? Well, the evidence is promising enough to turn research into a tantalizing new direction. Tom Ederle has the story.
Thief of memory, destroyer of minds. Alzheimer's is a cruel disease that has so far mocked the best efforts of science to conquer it. Always fatal, 4 million Americans suffer from Alzheimer's, and it kills 100,000 people each year. But certain groups, like the Cherokee Indian, seem to develop Alzheimer's much later than most other people, or they don't get it at all. That leaves doctors puzzled, but hopeful.
It's very encouraging that such subgroups are being discovered, because the indication is that there might be certain genes that have protective effect, or they delay the onset of the disease such that somebody will die off of some other disease.
But if some groups are genetically protected, which gene is providing the shield? The answer may come from a much wider and more thorough study of the Cherokee and other groups whose gene pools appear to keep Alzheimer's at bay.
The field is moving very rapidly in a very positive way. We just need to accelerate the process because there are so many people are being affected, and the numbers that are going to be affected are going to increase at a tremendous rate because the baby boomers are coming as a big bulge, and many of these baby boomers are going to be candidates for the disease.
Japan and Nigeria are two other societies that report little trouble from Alzheimer's disease. Is there some common link, genetic or even environmental? For now, there are more questions than answers, and much research remains to be done. But doctors think they're edging just a bit closer to defeating an age-old scourge. I'm Tom Ederle reporting.
Doctors say it's likely that genetic research will someday yield highly effective treatments for Alzheimer's, if not an outright cure.
With the spring season upon us and the nice hot weather just around the corner, we'll become more active, get outdoors and expose ourselves to the warm and somewhat dangerous sun rays. During the summer of 1980, heat stroke rates for the elderly were 12 to 13 times that of the younger population.
In fact, many of the elderly were more susceptible because of a lack of cooling systems, functional disabilities, mental illness, the use of risky medication, and concomitant medical disorders. Mortality rates from a variety of medical conditions rise during the hotter months. One preventable condition during the summer months is that of heat disorder. The topic of today's Medical Minute with Dr. Alan Abrams.
Disorder are of three types, each being more medically serious across the spectrum. The first is heat cramps. These are muscle cramps preceded by profuse sweating without a rise in body temperature. The second type is heat exhaustion, in which the patient develops nausea, vomiting, disorientation, and dizziness. Cramping may occur and the patient may be thirsty. The third and final stage of heat disorder is called heat stroke, in which the patient undergoes a cardiovascular collapse with a rise in body temperature but a lack of sweating. The patient usually loses consciousness. This is a medical emergency. Heat disorders can be avoided with some sensible caution. 1. Maintain good fluid intake daily. Remember, sweating requires additional fluids than ordinary, whether from exertion or sitting still. 2. Find adequate air conditioning in the hottest of days, even if only for short periods of time. 3. Wear light clothing. 4. Open and shaded windows with a fan when air conditioning is unavailable will reduce the risk of excessive sweating and heat conditions. And 5, avoid heavy exercise on the hottest of days. 6, discuss with your physician which medications might increase the risk of heat stroke. Ask if any of yours might reduce your best cooling system, sweating. Enjoy the great outdoors this summer, respect the heat when it arrives, and have a safe summer. This is Dr. Alan Abrams with your Medical Minute.
If you have any questions or comments for Dr. Alan Abrams, then write to him here at Time for Living, care of Medical Minute, P.O. Box 8452, Boston, Massachusetts, 02114.
Or again, you can leave a message on our voicemail by calling 800-232-7213, or just fax your question to 617-329-1774. Time for Living continues after this.
Welcome back, and thanks for joining us this week. Before we leave, we'd like to give you our address and phone numbers one last time so you can write or call us with your questions, comments, or suggestions, because this show is not only for you, it is about you.
So please write to us at Time for Living, P.O. Box 8452, Boston, Massachusetts, 02114, or send a fax to 617-329-1774. If you don't feel like writing, you can always leave us a message on our voicemail at 800-232-7213.
Well, we hope you enjoyed today's show. We look forward to seeing you next week, and we'll certainly have more interesting people and places to introduce you to. Until then, remember, it's time for living.
Take care.
Bye.